Guide to the graphic. In green, we have the gallbladder. In light blue, you have the small intestine. In dark blue is a sectioning of the pancreas. And in raspberry is the head of the pancreas. Pancreatitis. Acute pancreatitis is an inflammatory disorder of the pancreas resulting from premature activation of proteolytic enzymes within the pancreas. It is characterized by a discrete episode of symptoms with restoration of normal exocrine and endocrine function when the cause is removed. Chronic pancreatitis results in functional and structural damage to the pancreas that persists after the causative factor is eliminated. The disease is often progressive and loss of pancreatic function is irreversible. Pathophysiology. The etiologic factors associated with acute pancreatitis are ethanol abuse, 30%, and gallstone-associated biliary tract disease, 30 to 70%, accounting for most cases in the United States. A cause cannot be identified in 10 to 15% of cases. A number of medications have been implicated in acute pancreatitis, but a causal association is difficult to confirm because ethical and practical considerations prevent re-challenge with the suspected agent. Definite association is based on the temporal relationship of drug administration to abdominal pain and hyperamylasemia, or on a positive response to re-challenge with the offending agent. Suggestive evidence exists for drugs with a probable association, whereas evidence is inadequate or contradictory for drugs having a possible association. Acute pancreatitis. The pathophysiology of acute pancreatitis is related to autodigestion of the pancreas. Several mechanisms may initiate enzymatic activation within the pancreas, including reflux of duodenal contents containing enterokinase, activated pancreatic enzymes, and bile salts into the pancreatic duct. Disruption of the pancreatic ducts and extravasation of juice as a result of gallstone-induced ductal hypertension and intracellular activation of proteases by lysosomal enzymes. After initial acinar cell injury, pancreatic enzymes leak into the interstitium and cause edema and inflammation. Lipase damages fat cells, producing substances that cause further pancreatic and parapancreatic injury. Injured acinar cells liberate chemoattractants, and that attracts neutrophils, macrophages, and other cells to the area of inflammation. Leukocyte stimulation results in the release of a wide variety of destructive mediators such as elastase, platelet activating factor, reactive oxygen species, and cytokines. Prostaglandins, histamine, and kinins are released from the inflamed pancreas into the circulation, causing vascular permeability, vasodilation, and tissue edema. When digestive enzymes and toxic products of leukocyte secretion enter the circulation, they combine to produce widespread injury of extra-abdominal organs. Local complications include acute fluid collection, pancreatic necrosis, abscesses, pseudocyst formation, and pancreatic ascites. Systematic complications include pulmonary, cardiovascular, hematologic, renal, metabolic, and central nervous system abnormalities. Chronic pancreatitis. Chronic pancreatitis results in functional and structural damage to the pancreas that persists after the causative factor is eliminated. In contrast to ethanol-induced chronic pancreatitis, structural and functional changes may improve in obstructive chronic pancreatitis when the obstruction is removed. In most cases, chronic pancreatitis is progressive and loss of pancreatic function is irreversible. Permanent destruction of pancreatic tissue usually leads to exocrine and endocrine insufficiency. Cystic fibrosis is a cause of pancreatic exocrine insufficiency in children. Prolonged ethanol consumption is the main cause of chronic pancreatitis in the United States, accounting for approximately 70% of all cases, while half of the remaining 30% of non-ethanol cases are idiopathic. And that is pancreatitis. Have a great day.